Heart attack, myocardial infarction. Myocardial infarction, MI, also known as a heart attack, occurs when blood flow to a portion of the heart muscle is blocked, resulting in cell damage or death. Based on ECG findings and other clinical characteristics, various types of myocardial infarction exist. Here is a breakdown of the various types of myocardial infarction, their diagnostic procedures, and their treatments. ST segment elevation myocardial infarction, STEMI. STEMI is a type of MI characterized by the elevation of ST segment on the electrocardiogram, ECG. STEMI constitutes a medical emergency requiring immediate treatment to restore blood flow to the heart muscle. Reopening a blocked artery typically requires immediate coronary catheterization and percutaneous coronary intervention, PCI, with stent placement. This procedure should be completed within 90 minutes of the patient's arrival at the hospital, which is known as the door-to-balloon time. To reduce the risk of future events, patients may be required to take antiplatelet agents, beta blockers, and angiotensin-converting enzyme inhibitors, ACE inhibitors. Anterior STEMI. Anterior STEMI is the most common type of STEMI and is caused by a blockage in the coronary artery that supplies blood to the front of the heart, the left anterior descending, LAD, artery. On the electrocardiogram, ECG, anterior STEMI is characterized by ST segment elevation in leads V1 V4 and reciprocal changes in leads 2, 3, and of. Inferior ST elevation myocardial infarction. Inferior ST elevation myocardial infarction is caused by a blockage in the right coronary artery, RCA, or the left circumflex coronary artery, LCX, which supply blood to the bottom and back of the heart. On the electrocardiogram, inferior STEMI is characterized by an elevation of the ST segment in leads 2, 3, and of, with reciprocal changes in leads V1 V4. A blockage in the LCX coronary artery, which supplies blood to the left side of the heart, is the cause of lateral STEMI. On the electrocardiogram, lateral STEMI is characterized by an elevation of the ST segment in leads I and AVL, with reciprocal changes in leads 2, 3, and of. Posterior STEMI is caused by a blockage in the coronary arteries that supply blood to the back of the heart, RCA or LCX. Posterior STEMI is often difficult to diagnose on the standard 12-lead ECG, as there may not be obvious ST segment elevation. Alternatively, posterior STEMI may be diagnosed based on reciprocal changes in the anterior leads V1 V4, or by additional posterior leads V7 V9, which may demonstrate ST segment depression or taller waves. Right ventricular STEMI, a blockage in the RCA, which supplies blood to the right side of the heart, causes right ventricular STEMI. On the electrocardiogram, right ventricular STEMI is characterized by an elevation of the ST segment in leads V4 or V6R, with reciprocal changes in the lateral leads I and AVL. Non-ST segment elevation myocardial infarction, NSTEMI. NSTEMI is a type of myocardial infarction characterized by partial blockage of a coronary artery and elevated cardiac enzymes without ST segment elevation on the electrocardiogram, ECG. Patients with NSTEMI undergo coronary catheterization within 24 to 48 hours to determine the severity of the blockage and the need for percutaneous coronary intervention, PCI, or coronary artery bypass graft, CABG, surgery. Medications such as antiplatelet agents, aspirin, Plavix, beta blockers, carvedilol, metoprolol, and ACE inhibitors, lisinopril, enalapril, may also be prescribed. Angina unstable is a type of chest pain caused by a reduction in blood flow to the heart muscle as a result of a partial blockage of a coronary artery. There may be no ST segment elevation or cardiac enzyme elevations on the ECG. Patients with unstable angina require immediate medical care to prevent progression to myocardial infarction, MI. Medications such as antiplatelet agents, beta blockers, and nitroglycerin may be prescribed, and coronary catheterization and PCI or CABG surgery may be necessary. A silent myocardial infarction is a myocardial infarction that occurs without symptoms or with symptoms that the patient is unaware of. Typically, it is discovered during ECG or imaging studies conducted for other reasons. Patients with a history of silent myocardial infarction require the same treatment and modification of risk factors as patients with symptomatic MI. Typically, an ECG, cardiac enzyme testing, and imaging studies such as echocardiography or cardiac MRI are performed in the evaluation of a myocardial infarction, MI. Typically, a coronary catheterization is required to confirm the diagnosis and assess the extent of the blockage. To evaluate the functional capacity of the heart and determine the need for additional interventions, stress tests may also be administered. Me may be treated with medications such as antiplatelet agents, beta blockers, ACE inhibitors, and statins, in addition to lifestyle modifications such as quitting smoking, regular exercise, and a heart-healthy diet. It may be necessary to perform PCI with stent placement or CABG surgery to restore blood flow to the heart muscle and prevent future events. There are various types of myocardial infarction based on ECG findings and other clinical characteristics. Depending on the extent of the blockage and other factors, the diagnostic process typically includes an ECG, cardiac enzyme testing, imaging studies, and coronary catheterization, and treatment may include medications, PCI, or CABG surgery. If you experience any symptoms of a myocardial infarction, such as chest pain, shortness of breath, or dizziness, you should seek immediate medical attention, as prompt treatment can help reduce the damage to the heart muscle and improve outcomes. In addition to medical treatment, changes in lifestyle, such as quitting smoking, regular exercise, and a heart-healthy diet, can help improve outcomes and reduce the risk of future events. Patients with multivessel disease or other high-risk characteristics, such as left main coronary artery disease or poor left ventricular function, may be recommended CABG surgery. The CABG procedure involves using a vein or artery from another part of the body to bypass the blocked or narrowed coronary arteries, allowing blood to flow to the heart muscle. This procedure is commonly performed under general anesthesia and may necessitate a hospital stay of several days or more. In conclusion, the workup and treatment options are determined by the type of ME and degree of blockage. Immediate diagnosis and treatment are essential for enhancing outcomes and decreasing the likelihood of future occurrences. It is essential to collaborate closely with your healthcare provider to determine the most appropriate treatment for your unique situation. References: Eric, R., and K. Jacobs. Time to treatment in patients with STEMI Alice. The New England Journal of Medicine 369 No. 10, 2013. David, D., et al. The American Journal of Medicine 124 No. 1, 2011. Nina, W. van der Hoeven, et al. Cardiovascular Interventions 13 No. 10, 2020. Ioannis, Konakakis. Challenges and Unanswered Questions in STEMI Management. Hellenic Journal of Cardiology 60 No. 4, 2019. Michael, P., and R. Bates. Update on primary PCI for patients with STEMI. Eric. Trends in Cardiovascular Medicine 27 No. 2, 2017. Fabiana, Relini, and J. Angiolillo. Antithrombotic Therapy for Patients with STEMI Undergoing Primary PCI. Dominic. Nature Reviews Cardiology 14 No. 6, 2017. Grant, W., et al. The Lancet 389 No. 1006. Jeffrey, L., and A. Morrow. Acute Myocardial Infarction. David. New England Journal of Medicine 376 No. 21, 2017. Pierre, Theroux. Pathophysiology of Coronary Artery Disease. Circulation 111 No. 25, 2005. U. Joseph, et al. Radiology 232 No. 1, 2004. Lena, Badimon, et al. New England Journal of Medicine 326 No. 4, 1992. Saruis, Patrick W. Marie-Claude Morris, A. Peter Capitine, Antonio Colombo, David R. Holmes, Michael J. Mack, Elizabeth Stahill et al. Percutaneous coronary intervention versus coronary artery bypass grafting for severe coronary artery disease. New England Journal of Medicine 360 No. 10, 2009. Norman, R., et al. Coronary artery disease in peripheral vascular patients. A classification of 1000. Ann, Ty Bjarg Hansen. Genetics of coronary artery disease. Circulation Research 118 No. 4, 2016.